Thank you so much for coming to today's current topic session. This is current topic. This is really always a topic of interest, right? So physician-to-physician communication. And who better to talk about physician-to-physician communication than a family medicine doc. So Dr. Jimmy James Thompson is a family medicine doc here, and he also has an interest in improving the communication skills amongst our physicians. So we also have some other look at our series coming up. We have some physician-to-patient communication, those types of things. But this one will be primarily focused on physician-to-physician communication, so from a recurring doc. So please join me in welcoming Dr. James Thompson.
Thank you. So when I got this topic, I said, well, is there, like, what are the objectives? What are we going for here? And I was told, well, there are no objectives. You have to define those objectives. And I thought, well, is there a template? Is there a focus? And no, there really wasn't a focus. So anyway, I took it where I took it. And what I really hope is I'm going to present some information, but I really want to get most of our time together, or at least half of our time together, us dialoguing about physician-to-physician communication, because I think we have some work that we can do, and potentially this could be a nidus. My hope really is that this could be sort of the beginnings of a conversation that could trickle up even through to the chairs of ways that we as Carilion Clinic can improve physician-to-physician communication. So, a few things first. I am a family physician, and so we have, as one of the faculty for the family medicine residency, we are the only family physician group that still admit to the hospital and do both our outpatient and our inpatient care. So we have kind of a unique opportunity, if you would, and a unique view of different types of communications to physicians. Now here are some examples of some communication. These are chart bloopers. I thought it would be good to kind of smile a little bit. And so these are some examples of miscommunication that I got off of the doctor's lounge. So these were written in actual medical charts. All right, here we go. Number one. What's the miscommunication? She's a widow by definition, right? She no longer lives with her husband because Chad actually buried him, I guess, recently. Okay, how about this one? Yeah. Patient has no past history of suicides. Well, that's kind of obvious. How about this one? Is that an association or a causation? We don't know the answer to that. And then finally, you don't want that to happen if you admit a patient to the hospital, right? You don't want them to go out the same way they came in. So those are miscommunications in written form in the chart, but really today I want us to dialogue about just communication in general. Here are the objectives that we're going to go. We're going to look at some real-world examples of both good and bad communication. We're going to talk about the importance of this topic in general, because it's something that we don't get a lot of training in, quite frankly. And then collectively, I really want us to dialogue about what should this look like for Carilion Clinic. All right, so good examples. First of all, Carilion Clinic. We are Carilion Clinic. 2008 or so, somewhere around in there, we made this wonderful transition from being just Carilion Health Systems to being a clinic-based model. And so we have all these hospitals. You know, there's the flagship at RMH, there's Stonewall Jackson, there's New River Valley, there's smaller hospitals. I'm not dissing anybody, I just couldn't fit them all on the page. Right, and then we don't just have the hospital systems, we have all of these outpatient facilities. So Riverside is sort of the flagship collaboration of multi-specialists, and we have ION, which is neurosurgery and orthopedics. I put in my 2 family medicine offices there, which are important, and then Velocity Care. We have a whole urgent care brand that is now spreading all over the place. Carilion is a big system. We're talking all the time, we're communicating all the time, or at least we think we are. So I want to give a little bit of personal testimony in terms of things gone well. So this past year has been a busy year medically for my family. Most of my family members live an hour and a half away, and their medical system actually is not great, I would say. In general, if you want to seek good care, you go somewhere else. And so I've had several family members that needed some issues. So I had a family member that was diagnosed with breast cancer. And so I was able to get them plugged in here, or I recommended them to get plugged in here, and very quickly they saw the surgeon, they had the studies, they talked to radiation, they talked to plastics. I mean, all of that was really a very nice coordinated package where the various disciplines were truly communicating well. And they worked together well, the outcome was well, it was a great experience. Just last month, my mother, who's 78 and lives outside the community, she needed AAA repair. And that's dicey, as you know, and dangerous. And so what did I do? I referred her into Carilion. And so she came in, she had a great operative experience, post-operative care, ICU care, hospitalist care. It all really was very seamless and done very well. And then I would say even myself, I had surgery this past year, and once again, my experience was actually very, very good from start to finish. Nursing staff, the non-nursing staff, the physician staff, it really was good. Now, is that the norm? Is that typical? I don't know the answer to that necessarily, because I know that when you're caring for one of your own, there's a tendency to go a little bit above. But I would say that these experiences have been very positive. And I'm a Carilion, so I want you to know, here's a disclaimer, a bias up front, is I am a Carilion fan. I am a Carilion advocate. I've been affiliated with the Carilion system since 1993 when I came to residency. I think we do some incredible work here, and I think we have an incredible amount of positives. But I think our communication could be better, and I'm hoping that we're going to get to some good dialogue about that. Now, in the first objective, it was to look at some good examples, and I shared with you some good examples, and now some bad examples. So these are non-Carilion examples, so I don't want you to think these are Carilion examples, although I am going to share with you a personal Carilion example. So this was an article that came out February 2016 in Stats.com. Communication failures linked to 1,744 deaths in 5 years. Communication failures. That's important. It wasn't just a medical mistake, it was a communication failure that led to those deaths. In one instance, there are 3 instances I'm going to show you here. A nurse failed to tell a surgeon that a patient was having abdominal pain and a drop in red blood cells. The patient ultimately died, bled to death. Here's another one. Medical office staff received calls from a diabetic patient, did not relay the message. Patient never got a call back. Patient later died of diabetic ketoacidosis. A communication failure. And here's the third one. Woman wanted to have her tubes tied. It wasn't communicated. Patient filed a malpractice claim when she got pregnant the next time. All right? So these are communication gaps. This was a really intriguing article. It was actually posted online in 2015. And this young lady is she's an internal medicine resident, and she wrote this blog, essentially, When Doctors Don't Talk to Doctors. And she detailed an encounter that she had with one of her patients in the hospital. It was an elderly, demented patient who came in, and the patient was having internal bleeding, and it could not be stopped. So it was a slow internal bleed, apparently could not be stopped. It was a foregone conclusion that this poor demented lady was going to die. And the discussion was, should any heroic measures be done in the interim, knowing that was going to happen and happen fairly quickly. So the conversation, she could not eat. It was an intestinal bleed, apparently. She could not be allowed to eat. So the question was, I don't know where the level of the bleed was, but should a tube be put in, a feeding tube be put in? And so this resident and her team had a conversation with the patient's family because the patient was not able to make that determination. And it sounds like it was a tough decision, a tough conversation, tear-filled conversation, and the ultimate conclusion was Mama would not want this. She would want to die in peace. She would not want another procedure. She would not want anything done to prolong her life. And so they felt good about the conversation. They documented that in the chart. They came back in the next day to round on the patient, and the patient had a feeding tube placed already. Because the surgical team had come in and they did what they do. There was a need, and they apparently had a conversation with the family as well. The assumption was, the resident didn't know this in her blog, but bottom line was communication failure resulted in a procedure that was not necessary. Now the family was okay with it. She talks about how the family was okay and the lady was discharged and she went home and she died. But the comment on the part of this physician was that this was a classic example of communication gone awry that resulted in at least a procedure that didn't need to be done, and it could have resulted in pain and suffering. It did not, but it could have. So those are examples of examples in the literature, at least, when you look, of some bad communications. I want to share two examples personally that I've experienced both in the outpatient and the inpatient environment recently. The outpatient environment this week, I had this happen this week in my clinic. So the radiology department called my office because I had scheduled a patient for a CT scan. She was having weight loss, she was having pain in her lower abdomen, and I had scheduled a CT scan to evaluate that. And the radiology department called because they had some clarifying questions, and the patient was there. She was there at the radiology unit. And so one of my nurses took that call, fielded that call, put an entry in the electronic medical record. I'm on faculty, I'm not in my office all the time. I'm in different offices and doing different things administrative and educationally, and she sent that message to me. I didn't get that message until hours later, and so the radiology department went ahead and just made a decision. And they did an imaging study, and I think they did the right one and gave me the information that I needed. But that was a communication failure. Our policy in our office is very clear that when you have an outside phone call come in, that message should be verbally relayed to a doctor on site who can give an answer immediately for action. That's our policy. That policy didn't happen. It was just electronically put in, and so action was not taken. That could have resulted in delay of care or even patient harm, potentially. It did not, but it could have. An inpatient example is we had a patient on the inpatient service. This was about 2 months ago, and it was a lady, it was an elderly lady, and there was a dilemma, there was a diagnostic dilemma. She was having some type of bleeding internally, and the question literally was, is it coming from in the intestines, was it intraluminal, or was it outside the intestines? We weren't quite sure. We couldn't figure it out. We had both surgeons, we're family doctors, we had both the surgery team on board, and we had the gastroenterology team on board. But the bottom line was this woman was losing blood. It was a slow decline, but it was steadily declining. She needed to be diagnosed. She needed some intervention. And so the surgeons, after they reviewed everything, they said, well, we don't think it's coming from outside the intestines. We think it's a GI problem. We're not going to do anything. Okay, that's fine. The gastroenterologist reviewed the patient, and the gastroenterologist said, no, we don't think it's coming from inside the lumen. We don't think we can be of any benefit. We're not going to do anything. The surgeons need to do something. And so those were the first two initial reports that came, and as the primary care team, we thought, okay, well, this is a dilemma, but certainly one of the two of them will now say, okay, we've got a, the surgeons now will reply, I guess, to or respond to that and go ahead and do something. And the next day, the surgeons came around, they rounded, they put a note in the chart, and said, no, not us. And then we thought, well, what do we do now? And then the gastroenterologist came around, reviewed it a second time, and said, not us either. And here we were saying, what do we do? I would suggest to you that there was a huge gap in communication there, breakdown in communication in multiple ways. The surgeon and the GI doctors absolutely should have been communicating. If that was the question was which one should do something, rather than just put an entry in the chart, I would suggest they should have verbally dialogued. I would suggest that we failed from a communication standpoint as the primary care team because we were just reading the notes as well. We didn't pick up the phone and call until after the second day and call the GI doc or call the surgeon individually and say, okay, there's a problem here, we got to figure this out and collectively determine a way forward to help this patient who's bleeding. And we did eventually, and we did get her out. But there was a delay in care because of communication that seemed to be happening, but quite frankly, was really not happening. So those are examples of good communication, examples of bad communication. It happens. We're constantly communicating. So the question is good physician-to-physician communication important? When you search and try to find articles on physician-to-physician communication, it's really fascinating. There's not a lot out there that talks about us communicating to each other. Tons of articles on physician-to-patient communication. Lots of articles on physician-to-nursing staff communication or physician-to-other care member communication. Not a lot on doctor-to-doctor communication. So this is really interesting. I saw this and thought it was fascinating. 23,000 plus malpractice cases were reviewed from 2009 to 2013. In that review of 23,000 cases, over 7,000 cases were communication failures. Now this wasn't just doctor to doctor, it was all comers, but still it's highlighting communication. And Joint Commission, you can't see the little green there, Joint Commission estimates that transfer of patients, like from daytime to nighttime, coverage type transfers, and that is a physician-to-physician issue, contributes to 80% of serious medical errors. Delays in or problems in communication. In 2010, Joint Commission said this: communication problems were the most commonly cited cause in root cause analysis of sentinel events. Communication. Not processor errors, really, communication issues. And so then there was a great article that I read that talked about why. Why do we not get it right? We, by definition, our field is all about communication. That's what we do all day long. So these are 3 possible barriers to communication that have been highlighted in recent years. Number 1, physician groups are getting larger. So for anybody who's been around here a long time, you know, it used to be pretty common. You just knew everybody. I mean, you probably knew everybody around here, right? You knew the cardiologist, you knew the gastroenterologist, you knew what they were capable of, you knew when to send the patient here versus there. You just knew each other because you interacted with each other in the hospital environment, outside the hospital environment. And now, as physician groups have gotten larger, you don't know each other. And so that decreases communication. Increased use of asynchronous communication. We think if we text, we think if we put an entry in the medical record, that it's going to be communicated, it's going to be acted upon. And yet it's not always received in a timely fashion. It certainly is not always acted upon in a timely fashion. We have a lot of asynchronous communication fatigue, I would suggest. And then finally, there's not a lot of training on communication into other specialties. So there is training in disciplines of how to communicate to each other. So the internists know how to communicate to the internists, family doctors know how to communicate to family doctors, et cetera, et cetera. But communicating across specialties is not focused on very much. So those are some suggested barriers to communication. And then there was an article in 2014, Is Your Doctor Talking to Other Doctors? There was this lady doctor from Alexandria, Virginia, Dr. Val Jones, and she is licensed in 13 different states as a locum tenens physician. And so she goes all over the place. And what she posits in this article was that she was concerned when she practiced in her home location that the communication issues that she saw there were unique to her system. And then she started to get licensed in all these other states and go practice in all these other systems as a locums physician. And what she recognized was that it was universal, that people were miscommunicating all over the place. And I loved this particular statement that she said. I highlighted it, so the underline in bold is mine, not hers. No one talks to each other anymore. And she kind of boiled down all the things that she was seeing. That was one of her big take-home points and messages. So I guess I want to open it up here for a bit to hear your thoughts on all of this. So have you seen examples of of miscommunication leading to delays in care, leading to patient errors or anything of that nature. So I'd love for you to share what you have seen or what your experience has been.
We see them all the time. I can't think of a very specific one, but we see them all the time.
I recently so just last week with a patient in one of the critical care units with a possible diagnosis of ANCA vasculitis. Nephrology was consulted and the nephrologist attending, he put in his note that plasmapheresis is available at Carillion again when during a certain period of time we didn't have a plasmapheresis anymore. We had to transfer the patient to UVA, for example. So that's what he noted in his documentation of the patient encounter. So my patient is not getting any better, has respiratory failure and kidney failure. So as the attending, it was getting late, I placed the catheter to start plasmapheresis right away. So I placed the catheter, and then we call nephrology and say, hey, the catheter is in, we can start plasmapheresis tonight. And the nephrology attending that was on call that night, he said plasmapheresis is not available. This is a different attending, right? So in this confusion, I mean, I placed a catheter that I've done it a million times, but can potentially be associated to a complication. It's an invasive. The patient didn't have a plasmapheresis. I had to talk to the patient and the family and apologize for this or miscommunication.
That's a great example.
Not very specific examples. One of the things that I think we have brought up many times, having worked in different hospitals before, I think part of the reason we don't know each other is that we don't have, as you said, that contact, and it's harder to talk to somebody that you don't know. If I know you and I have a question, I'm like, I'll just give them a call and see what's going on. If it's somebody I've never met, it's a little there's a little barrier there. And we've repeatedly said that we really should have like a physician's lounge where people get to know each other, and inside the hospital you interact with each other, and we don't. In places that I've worked with before, we would see each other like around lunchtime or afternoon break when you had like a time to grab a cup of coffee or something all the time. So everybody knew everybody. Now it's like I hear the name of somebody, but I have never seen them. So we brought this a few times, and I don't know why there's such a resistance to having that. I think it'll definitely help with people knowing each other and communicating better.
Yeah, in days gone by, the physician's lounge and the library seem to be the two places that we would intersect the most. And now with everything electronic, we don't go to that little library hardly.
Exactly.
And there's no lounge. Yes.
As you noted, I'm the oldest one in the room, and have...
Well, I wasn't saying the oldest one, Faith, but maybe the one who's had the most experience here in the system.
Right. Well, that's fine. Yes, it's nothing like meeting the person face to face and knowing the person. Now, I grew up doing that in my early years, and now when I call in and try to get a position, it's a real fight. I don't do any hospital work, but I refer people in. When I try to refer them in, it's a real fight to get somebody to get me to the real doctor. I feel like I don't need to talk to the secretary or the nurse or the PA or the nurse practitioner, because I've done all that background stuff and I'm ready to say this is a really sick patient. But it's hard for me to get through. The only way I've been able to do it is to actually page the person. And sometimes I've said to the secretary or the nurse, now, I need to talk to this person just today. I need to talk to them soon. If you can't get at them, I will have them paged and have to be very assertive with doing that. So I don't like to be that pushy, but if the patient needs help, you have to do that. So, and when I get a hold of the doctor, it's always, oh, thanks for calling me. Because they wouldn't have heard about it for days or even hours or even a day. I like to do that instead of going to the emergency room. Now, when I've tried to send people to the ER, I also like to call because I think that's polite for them. Instead of them getting the history from the patient, I should be able to tell them what's already occurred, because I've already done that. But sometimes I call the emergency room and they talk to me like, really? You want to talk to the doctor? I mean, that's like a dinosaur. So we've got to train our doctors to expect those calls and to realize what great information you can get just by speaking. I mean, I can give that history in a flash.
Yeah, it's really interesting that you say that, because I think maybe learned helplessness almost. I've stopped doing that because I'm no longer convinced that the information that I give to the person that I talk to on the other end is going to eventually wind up in the hands of the person that's actually going to see the patient.
That's true.
I have talked to doctors in the emergency room about a patient coming in. The problem is that then another doctor ends up seeing the patient,
Right.
and then you ask them, like, well, the other one didn't tell me about it.
Yeah.
So, yeah, I've stopped doing it too, because it's,
Sometimes I
It's
say,
not going
would
to
you
the right
write this
person.
down? Would you write this down? So, because I don't trust that verbal communication either.
Right, yeah. Yeah, good.
You know, in the IM program, we require them to call the consult, at least call the consult. They can't just write it in the chart automatically, they have to call the consult. And I think that's helpful. I don't know if that's in any other, I think that that's a Carillion thing, but we require them to do that. They
We
have to-
require it in the family medicine program as well.
And that's very helpful. And the other thing too, I think, we've been on time, you know, when you're on rounds and you're rounding for whatever, 3 hours or so, and you see a patient and you have this communication, and if you don't get a hold of the consultant real fast, like you say, when I get back to my desk, I'll call, they could swing in there
Mhm.
and then they're not privy to what you're saying. So it's, even just getting, I just so much appreciate a consultant, like you said, not text, but at least if they text, hey, we're taking them for colonoscopy today, you know what, that is extremely helpful because it's real time. I might be seeing the patient, I don't know what's going on. They haven't read the note yet, not because of a fault of their own, but because they're busy seeing patients. They haven't had a chance to write a note yet.
Right.
But I think the familiarity of what you were saying, like the pulmonologists are right down our hall, and I don't know how many times, like I've gone down the hall, like going from door to door, like who's here, right? And then Maddie just, yesterday, she came in, she saw a patient, she goes, I saw the patient, I knew the patient from before, here's what I think. It was so incredibly helpful. And even with, and they know, sometimes you call and you can't talk to a person. Like there's one, I won't beat up on any particular service, but there's one outside Carillion service where they will not let you talk to an attendee. You have to call through a service, and you even if you wanted to, you couldn't do that. And so I've gotten around that with if I know my favorite so-and-so specialist is in the hospital, I will call them, and then they will take care of it. I'll purposefully reroute it on purpose because I get so annoyed by it. And the pulmonologists know too. I mean, when I get a consult with a pulmonologist, I'll find a pulmonologist that's on for pulmonology and I'll talk to them. And maybe I'm circumventing the system, but they say they don't mind. I don't think they mind. Yeah, but I think we just have to be really aggressive about it, like you were saying.
I think that also the issue with electronic medical records is the delay in note
Right.
writing.
Yeah.
Because it used to be you go to the patient's bedside, you write your note while you're there, so the next person who comes can just look at your note and say, oh, okay, they're going to do whatever procedure today.
Yeah.
Now you go to the bedside, see the patient, you walk away, and the notes may not be done for another hour or two because you're seeing other patients.
That's true, yeah.
So what the next person who comes in is like, I haven't, and the nurse may say, well, yeah, GI was here or pulmonary was here, but they don't know exactly what's going on.
Right.
And that communication, even though you have an electronic medical record that's supposed to help you communicate, is kind of delayed.
There was, so in the very few articles I could find that even talked about this issue of physician-to-physician communication, the EMR was highlighted as a barrier to
Yeah.
communication, but I never could see any specifics about how the EMR was a barrier. But that certainly is a very specific one, that there's a delay in seeing the patient and the documentation could happen
Hours
a lot
later.
of time after that. Yeah.
Plus there's copy paste. I mean, I'm not I love the EMR, so I wouldn't go back to paper for the world, but in the paper you got down to like what you needed to write, and it was
Right.
very important. So if you wrote 5 lines, you don't want to write 17 pages.
Right.
In the EMR, you get all this garbage that gets thrown in there, that gets copy forwarded, and you're looking for the one sentence that is important, and sometimes it gets lost, or it doesn't get put in there, and then you have to call them anyway, so very much that technology has good and has bad with it, but very big problem.
Because I'm actually a dietitian, so, I'm trying to communicate
Yeah.
physicians, not physician to physician. But surprisingly, one of the good things that I found was using our EMR to have a template so that when they open my note, they know exactly right there, the first sentences are what they need to know. Everything else, it just backs up why I'm making this recommendation. So, and I actually got feedback that they like that because it makes it quick.
Yeah, same with the therapy notes. I mean, I don't want to read a 3-page therapy note. Just tell me if you think they need to go to a skilled nursing facility or they can go home.
Right. And I think that was a recent change in the system to put that assessment plan at the top.
Well, actually, the way we're charting for dietitian goes, it would be a different format. I don't chart in the recommended format for dietitians, actually, because I don't think it's a good way to communicate. Because you have to write this statement that says, this is your diagnosis and then blah, blah, blah. Well, the physician doesn't know that.
Right.
I mean, and I don't pull in labs or anything like that, because it just makes the note loud. And I think if
Right.
somebody wants the labs, they go to the lab section and look at them.
Yeah, the note below is significant. Any other thoughts or?
Across care settings, I find the EMR to be helpful. Acute care, no, but in our patient population, when patients are, headed home to hospitals, I can send an Epic note, attach the chart, and I don't want to talk to the doctor, but I want them to know, and then they get back to me, and I also use it for psychosocial information, like, we're kind of concerned about how the wife's coping with this. Oh, she's my patient too, so I find that Epic to be really helpful with that, with the non-urgent but important conversation, so because the doctor can get to him. I don't want to interrupt his day, but I hopefully can. And maybe I've just been lucky that the person that I'm communicating with does his Epic messages and gets back to me in an appropriate time.
I would agree, the non-urgent is beautiful.
Yeah.
Having it all and all the disciplines right there where you can see them, it really is so much better.
And your patient did fine, by the way, and I let his PCP know what's happening, the children, and I was really pleased with the outcome she passed yesterday. Yeah. But based on her choice.
This ties into my question, the people who are not in the Epic system, who are referring patients into this system, how do you contact them and let them know? One time I sent a patient to a surgeon and never heard a word, never heard anything. I assumed she had not been operated on, and they decided not to do surgery. She came back to me with a scar in her belly, and I was embarrassed that nobody had told me that surgery had been done. She had been going to see her other doctor.
Right, that's a great
It was
question.
not in the Epic system at
I don't
that
know the
time.
answer to that question.
Well, they'll do, Epic, so Epic's got a routing button where they can route it to the primary care doctor. And so the residents, they'll do this quite frequently. They'll write this beautiful discharge summary, and it's detailed, and I've gone over it. And it's like, and then I ask them, well, how's the primary care doctor going to read your beautiful masterpiece and your communication? Like, I don't know, they'll request records. I said, have you requested records recently from an outside facility and seen how long it took? And so half of them, they still don't know it. I think there's second and third years that still don't route the discharge summaries to the primary care docs. But, and they're 25%, I think the rate of readmission is like 25%. When the primary care doc does not get the discharge summary by the first visit, they're 25% likely to be back to the
The
hospital.
literature on that is pretty significant.
Yep.
Yeah.
I mean, it is, Epic is set up so that you can communicate your notes immediately, but other people have to look at the communication. So, but every operative note I do is I route that operative note to the referring physicians so that they have the operative note in Epic.
And what if they're not in Epic, so that space point?
Well, that's the problem. If they're not in Epic, then it's a problem. It can still, then there has to be some additional way to.
But if you're routed to the fax number.
Yeah, if you route it, if they're in the system, then if they're not in Epic, it gets faxed.
It will still get
It gets
faxed to them.
automatically
Okay.
faxed.
But that presumes that somebody is, that the fax is, you can't, you have no confirmation whether that fax gets received and if it gets in that.
Right.
They're in West Virginia. Is there any, y'all are telling me that
If
there's
they're,
really...
there is a
if they are a
system, if they're in
referring
the
physician
system.
to us, their fax numbers are generally in there. If they're not,
If they're
then
not, if they're not in Epic?
if you
Yeah.
can't
Yeah.
find them, then.
Yeah, every patient should have a referring physician listed, and if they're not in Epic, then there's a way to send those communications.
And even other physicians in Roanoke Valley who are not in Epic, they're listed in Epic as well. So, well, that's a great segue, because I want to segue to the third point, and that is, what does it mean to be Carilion Clinic? And what does communication, what should it look like? So, you know, here's my personal opinion. My personal opinion is at Carilion Clinic, I think we're good. I wouldn't work here if I didn't think that, quite frankly. I think we're good, but I think we should be and can be better. So I went to the Mayo Clinic website because as Carilion was turning into the clinic model, we heard a lot about the Mayo Clinic, and Carilion investigated other clinic models, Mayo and Cleveland and other places, to use as sort of a foundation for what we could look like. And then we went on this massive hiring spree, and I think we went from like 300 Carilion employed positions, something like that, up to 600 to 700 Carilion employed positions, this massive hiring, and really doubled our size as a medical staff. So when you look on Mayo Clinic and you look at their history, it's really fascinating. The things they've done is quite fascinating. I was more impressed after I did this research than before. So this was one of the things that was a hallmark value of the Mayo Clinic from the very beginning, and the underlining is mine, not theirs. They were initially viewed as unconventional at their time. It was in the early 1900s. They were viewed as unconventional because they had a mindset from the very beginning that medicine needed to be a team, essentially. That they were going to be physicians as a private group, keyword group, not individual, that were going to be working together for the good of the patient. And this was the initial stone, if you would, on their first facility that it opened. And the Mayos were, you all may know this, I did not know this, were actually a family of doctors. There was a doctor, I forget his first name now, but there was a Daddy Mayo, and then he had two sons. And I have a couple of quotes from the two sons. So Dr. William Mayo, he was the oldest son, and in 1910 he said this: "The best interest of the patient is the only interest to be considered." They were all about patients, quite frankly. And in order that the sick may have the benefit of advancing knowledge, union of forces is necessary. So their innovative approach was, we've got to bring together all of the different pieces that can get this patient well. And they were not afraid to ask for help when they didn't know the answer. And that was exciting and unique at the time. This is his little brother, Charles. In 1916, he was quoted as saying this: "The keynote of progress is system and organization, in other words, teamwork." 100 years ago, 1916, teamwork. And they set about creating and crafting this interdisciplinary medical team that has been nigh unstoppable. And I didn't even know, if you look on the Mayo Clinic's website and you look at their history of innovation and the number of medical advances that we take for granted, like the first CT scan was Mayo Clinic. It's things that we do every day in our common medical practice, and it started there through the years. And then they grew, and they have a Mayo Clinic in Arizona, and they have a Mayo Clinic in Florida. You know, it started in New York, and they've got all this whole Mayo Clinic network. But their values have not changed. The values of teamwork, the values of communication, the values of this interdisciplinary process. And my understanding, when I've had patients and friends that have gone to the Mayo Clinic, they go in the doors, and all of a sudden, any provider that needs to be pulled into the care of that patient, regardless of the discipline, it happens. And it happens quickly, and it seems to happen seamlessly. I don't know how that happens. But my question that I want to pose for us, and this is really the last question, last topic of the day, is, as we are Carilion Clinic, tagline, finding better ways, I would posit for our consideration that we have to find a better way to communicate. Because right now, as impressed as I am with who we are and what we do, I still think we're not truly there in terms of being a clinic. We still are almost, we just recently had, in the past 2 years, we added counselors, behavioral health therapists to our office because we had such a high rate of patients that were showing up in the emergency room that were showing up because of psychiatric or mental health reasons. 50% of our patients that go to ED have a primary mental health issue. So we really thought that if we could bring counselors into our office, we could decrease that emergency room utilization. We did some other things as well. It was successful. I'm not sure how much of that is attributed to just the counselors, but I was talking to our psychologist and I was talking about our integrated care, and she said, no. We're not integrated right now in the true form of integrated in terms of my practice and them. We are co-located. She said, we're on the same site, my behavioralist and us family doctors, we're on the same site, but we're truly not integrated yet. And so many times when I think of Carilion Clinic, I think of that same reality. We're on the same site. We got tons of different disciplines, and we're all here. We're at Riverside, or we're at Ion, and sometimes that works very well, but in many situations it seems like we're not truly integrated, we're co-located. I think the referral shell, if you would, is an example of that. I send a patient I refer them to, neurosurgery, gastroenterology, and I put in the order in Epic, and somehow my referral coordinator sends it somewhere to some electronic desktop, and there's somebody at that electronic desktop that is supposed to be working that queue, and maybe they'll get an appointment, maybe they won't. Where in days gone by, the patient would be at the checkout window, and my receptionist would call the GI office, and they'd say, Mrs. Smith needs an appointment? Yep, 2 o'clock on Wednesday, here you go. And so I would suggest that we have a little ways to go before we stop being co-located and truly are integrated. So my question for this group, I think this is could be a good place to start, is how do we get there? From a communication standpoint, how do we become Carilion Clinic in the fullest fashion possible? Yes, sir.
I think although we're on Epic and everything is EMR and we send messages to each other and refer us and expect consultations from the consulting physicians, I think nothing replaces the verbal personal communication. And I don't know, I did my L modules to the last minute last night, and there were a few examples of failed communication which resulted in litigation. And I see that every day in my own practice, that the failure to call each other and talk to each other leads to not the ideal outcomes. Mm-hmm. Okay, I've been in the Carilion Clinic for 3 years. So if I cover my name here, I bet most of these people in this room, they don't know who I am. They may have heard my name, and I have to admit, I don't know you very well because I don't go to a lot of conferences. So I decided to come to this one late because I thought the topic was superb. But every day I see how the lack of the personal communication leads to bad outcomes. And I can give you a few examples. So a couple of weeks ago, I saw a patient who had a pheochromocytoma. He had it operated on, but he's got a little hypercalcemia, so he was referred to me. Maybe he's got also hyperparathyroidism, maybe MEN2A syndrome. So I was fascinated by his story. So to make the long story short, he came in with various symptoms, but the main one was, some vehement vomiting after he consumed a steak in July of 2016. So he was referred from New River Valley Hospital down here. He was diagnosed with a weird pericardiomyositis. He tested me, he was given antibiotics. He was released. He was to follow up with the cardiology. His main complaint is, he said that he didn't understand the people talking to him. He insisted, seriously, that they didn't speak English. And he kept going on this. He saw several people who didn't speak English. I think they didn't speak Southwest Virginia accent. But anyhow, so where am I getting with this? Well, in the midst of his workup, I think they wanted to rule out, a PE, because he had, cardiovascular events and elevated troponin. They did a CT scan, and there was a 5-centimeter adrenal mass, okay? So in the midst of all this big issue with the cardiac referral and the weird cardio or pericardiomyositis, when he was sent out of the hospital, the discharge summary that was to follow up with his cardiology and primary care, the primary care failed to recognize that there was a big adrenal mass. So I'm questioning, so what is the big deal for the resident on the team or even the attending physician? Pick up the phone and call that person's primary care physician and say, listen, he came for what we think might be an unrelated issue, but we found a big adrenal mass in his adrenal gland. So can you please take it from there? Why wasn't an endocrinologist notified? There's an adrenal mass. Do you want to see this patient in your office? Do you want to come by and see them? None of that happened. The patient went on to have classic FEO symptoms for about a year that culminated in another admission in June of 2017. He came in with another cardiovascular emergency, MI, and he was cut both sides, both times. The first time he had a 60% obstruction that they thought it was not resulting in an MI, the second time a 90%. But eventually his blood pressure was like 350/200. I mean, he was out of this world.
Right.
He had a very significant vascular emergency, hypertensive emergency. So he hardly made it, really.
Right.
He was finally treated and his fear got out. But this is an example of where if somebody picks up the phone,
Right.
like you said before, just because you copied the discharge summary to the primary care physician, he's not going to go in there. And he had like a list of 6-8 problems that he recognized were addressed during this admission. It was
Right.
bewildering to him. He never.
And that's there was one slide I had of a doctor who said, we don't talk to anybody anymore.
Yeah.
And that's an example of that. And as a primary care physician in the outside, getting these discharge summaries, it is so easy to overlook things. And partly because, the discharge summaries, if you guys get them, you know that everything known to man is in them. It's not like that concise discharge summary we used to get in days gone by, and so it's so easy to...
And the patient claims he was not told.
He was not told.
He had, and I don't think if the lawyer looks at the record, they're not going to see that he was told he has that. Somebody mentioned it on the discharge summary, but nobody wrote, I've told the patient, you got an adrenal mass, you better talk to your primary care physician. He's probably going to send you to an endocrinologist.
It gets a little off subject, but one of the studies that I saw, and it was doctor-patient communication, not doctor-doctor communication, actually cited that patients only hear about 40% of what they're told, or only will articulate about 40% of what they're told, and half of that 40% they articulate incorrectly. So they misunderstand it. All right, so more verbal communication with important things. What else can we do as Carilion Clinic to truly have this clinic model working?
Again, we just did some communication training for physicians, and half the class there was Mayo physicians that will be teaching communication training. So they have mandatory, everybody at the Mayo Clinic has to do an 8-hour communication training, team communication, patient-provider communication, and everybody has to. And they just talk about, and it's led by the physicians, and they pick champions and they train them in communication. So they invest in it.
That program was actually started by a young neurology faculty member, and she had the idea, and they they rolled it out as first non-mandatory.
Yes.
And then once they had hundreds of people sign up for it, it was so successful, then they made it mandatory for everybody.
Right, and they talk about, you know, you get classes where everybody's, again, I want to be here, and then they get the classes with the department chair, and then they have to be there, and they're made, and how you work through different, you know, learners and where people are with their communication, whether they have insight into their own communication, and you know, and obviously, I think my main point is that they invest in it.
Yeah, that's a great point. Other thoughts?
Again, to reiterate that physician lounge idea, that familiarity, getting to know people within your community is really, really big, so, yeah.
There's an email right now asking if we want to go to a provider social of some sort,
Yeah.
Right.
which is after hours.
Yeah.
I mean, it's a great thought, but I think if you had something on site and kind of during business hours that people could just kind of stop by, or you have a room that, you know, you can go sit down, have a cup of coffee and get to know a few people.
Right.
It works a lot better than having a social every few months that probably a handful of people are going to show up to.
Yeah, I took a break from Carillion and was at an overseas mission hospital between 2008 and 2012. And when I came, and we migrated to this clinic model really while I was overseas. A lot changed in medicine, the medicine landscape in that time period here in the U.S. But one of the things that I know that changed locally, and I think it's just a reality of modern day medicine, is doing things after hours has become a lot less popular or sustainable. And that's true even like medicine grand rounds at 7 o'clock on Friday mornings or whatever. It used to be packed, and now there's just a smattering of people there, it seems like. And medical staff meetings, you hardly see anybody there. So people don't want to do stuff
And
after
they
hours.
truly like going off-site after hours. People are not, I mean, people have families, they want to get home to their
Yeah.
kids and all that, so
It's a solid thing.
I think that's a problem. I mean, it's a great idea, but you get a handful of people there.
Well, I'm in the Carillion email as J.E., James Edward Thompson at CarillionClinic.org. If you have other thoughts, other ideas of how really we can continue this transition, I think us being a clinic, and I'm not speaking in any leadership capacity, I'm just speaking as a staff member. I think of us being a clinic, I think we're getting there. But so much of us are still sort of co-located as opposed to truly integrated. So if you have other ideas or thoughts of how we can continue to make this journey, send them to me. I'm going to do this. I'm going to compile the thoughts you've already articulated and whatever else you offer, and I'll send that to my chair. And he can take that into leadership. So I would welcome those emails.